Let me share my screen. Yeah, give me a second. So in the first session, we talked about we revised the basic electrophysiology of the heart, and then we went through. Guys, give me a second. Yeah, sorry about that. Anyways, yeah. So in the first session, we talked about the basic electrophysiology of the heart, and then we went through like the classification of arrhythmias, all the different arrhythmias, and then we went through the core mechanisms behind how arrhythmias are generated, like the basic principles behind arrhythmias we talked about, and then we talked about. Then we went on to talk about the specific arrhythmias. So last time we finished these arrhythmias. These ones. Okay. Last time we finished these arrhythmias. So we finished the sinus node arrhythmias and the atrial arrhythmias. So today what we have are the junctional arrhythmias, ventricular arrhythmias, heart blocks, and bundle branch blocks. Okay, so yeah. So and after this, I'll also be uploading another note like on these ones, the antiarrhythmics and the management of arrhythmias, as well as some cases. So I'll be uploading a document for that. I mean, I don't think there's a need for a back for that. Yeah, so I'll be uploading a document for those ones, but like the rest of the other the arrhythmias we will talk about today. Okay. Yeah, so before we go on to talk about junctional node arrhythmias, let us quickly revise through again the core mechanisms behind arrhythmias, because this is the most important one. Because if you can explain this, then you can pretty much explain every arrhythmia, how it's generated, like the pathophysiology behind every arrhythmia you can explain if you know the core principles. So how exactly are arrhythmias generated? Like we said in the first session, the first one is abnormal automaticity. So that can be non-pacemaker cells acquiring phase 4 depolarization. That is basically atrial or ventricular myocytes acquiring pacemaker-like behavior. Normally, they should not be giving impulses, but due to some pathological reason, they are they have an intrinsic spontaneous depolarization rate, but due to some pathological reasons, it goes up, and ultimately that starts to become the dominant pacemaker, like surpassing even the SA node. That is what is meant by non-pacemaker cells acquiring phase 4 depolarization. And the reasons why they acquire phase 4 depolarization, that's in this box. Okay. So, yeah. So that is in this box, and try to find out the reason for each and every one of these, like the mechanism behind each and every one of them. Other things that can happen include latent pacemakers escape or accelerate. So that is basically something like, so the SA node is the dominant node. So, but due to some reason, some pacemaker lower down in this hierarchy, that becomes pathologically accelerated. Like their intrinsic rate becomes higher than the SA node, and then they become the dominant pacemaker. That is again due to some pathology that is also included in this one. Okay, and the other thing can be existing pacemakers firing excessively. That is basically due to some reason the SA node starts firing at a faster rate. Okay, so that is basically what abnormal automaticity is. Okay, yeah, and the next core mechanism behind arrhythmias is triggered activity. First of them is early after depolarizations, and the second one is delayed after depolarizations, DADs and EADs. Okay, so give me a second. Yeah, okay. So when you're going to talk about these ones, early after depolarization, what happens is basically that's what happens there is an reactivation, an abnormal reactivation of L-type calcium channels during phase 2 or phase 3 of the cardiac myocyte. Okay, these EADs and DADs, remember, they are generated in the cardiac myocytes, atrial or ventricular myocytes. Okay, so most often this happens during phase 3. What happens is, if due to some reason phase 3 is prolonged, if it becomes a curved, if the curve becomes something like this, okay, Then what happens is, during this phase, during a window of -40 to -20 millivolts, calcium channels start to open again. Usually, the time window is too small for calcium channels to open because, like we talked about earlier, they are slow to open and slow to close. Okay, so since they are slow to open, so so calcium channels, remember, like let's revise what we said in the first part. So they start to become activated at around -40. Okay, then they start to become activated. But they truly open, it takes a little bit of time for them to truly open. So they usually, in a cardiac myocyte action potential, they usually open by the time the myocyte is at around +10 millivolts. And then again, they're slow to close. So they have a phase, a plateau phase. And after that, at around 0 millivolts, they close back up again. But when it goes down, okay, so once it's in the -20 to -40 range, it potentially can reopen again. But that usually doesn't happen because this time period is too small. Because they are slow to open and slow to close, then they need a longer time for them to open. So then so normally that doesn't happen because the time is too small. But if due to some reason this is delayed, if it becomes something like this, the time window increases. Then calcium channels, these are L-type calcium channels, they can reopen and calcium ions come back into the cardiac myocyte and depolarize the membrane. And remember, during this time, the sodium channels are in the relative refractory period. Okay, so that means they need a relatively stronger impulse, a stronger than normal impulse for them to fire. So if this calcium influx, if this current generated by calcium influx is sufficiently large enough, then sodium channels can reach threshold and then they can also start activating. So at around this time, calcium channels slowly start to get activated and increase the membrane potential, basically to depolarize the membrane. And if sodium channels get activated, then membrane potential shoots up like this up until like +20 millivolts, something like that. Okay, so then that is called early after depolarization. So early after depolarizations, they can slowly come down and die away like this, or giving rise to a premature atrial or ventricular depolarization. But remember, EADs usually happen in the ventricles. They don't usually happen in the atria. So they mostly give rise to PVCs, premature ventricular contractions. And sometimes they can be like if the conditions are good. Okay, so if the conditions are good, so that the phase 3 is prolonged for a prolonged period of time, then what happens is that this cycle can start happening repeatedly. Then what you have is a repeated pattern or something like this, and this generates a tachycardia, okay, a sustained tachycardia. We call this a triggered tachycardia, okay? Because tachycardias can also occur due to automaticity. If there's an abnormally automatic focus, okay, if there's an ectopic focus that produces signals at a rate faster than the SA node, then that can also lead to a tachycardia. This is another mechanism which can lead to a tachycardia, and when tachycardia comes to this mechanism, it's called a triggered tachycardia. Yeah. So that is basically how early after depolarization happens. And these are the reasons why phase 3 is extended. Phase 3 or QT, the QT period, okay, the QT duration is increased due to these reasons. You have to be familiar with these ones, okay, like the pathophysiology behind it. Okay, so next mechanism is this one, delayed after depolarizations. What happens there? Well, what happens there is that basically happens due to intracellular calcium overload. Now, intracellular calcium overload can happen due to these reasons. Okay, let me put this in a box. Should. Good. Okay, so calcium overload in the cell can happen due to these mechanisms. We talked about each and every one of them yesterday. I'm not going to go through them again, but be aware of them, like how it happens. But anyways, calcium overload. And calcium overload, this type of thing usually happens during phase 4. Remember, EADs happen during phase 2 and 3. Okay, they happen during phase 2 and 3. This happens during phase 4. So during phase 4, if calcium abnormally starts to increase in the cell, again, sodium channels can reach the threshold. And the usual threshold is at around like -55. Minus 55 millivolts is their usual threshold. And once they hit them, remember in the relative refractory period, it might be a little bit higher because they need a far stronger impulse. But here, now it's like perfectly, everything is back to normal. Everything is in the, every sodium channel is in the resting phase. So if by some chance the calcium influx is enough to generate if it's enough to take the membrane potential to a voltage of minus 50 millivolts, then sodium channels can start firing, and then this can reach another action potential. Okay. So again, here this can also lead to a single beat. Okay, so that can be a premature atrial contraction or a ventricular contraction. Remember, DADs can happen in the atria as well as the ventricles. Okay, so that can lead to a single solitary beat, or if the conditions are good, this can lead to a sustained tachycardia, a triggered tachycardia again. Okay? So that is how early after depolarization works. The other core principle we need to know about is how a re-entry circuit can be developed. Now, re-entry circuits basically happen like this. So usually, in a normal heart, the cardiac myocyte should conduct all impulses heterogeneously. Homogeneously. Like everything should function in the same way. But due to some pathologies, these can be altered. So there can be some areas which conduct impulses faster or at the normal rate of conduction, and there can be some areas which conduct them slower. And we also talked about the mechanism yesterday. Areas where conduction is fast, the refractory period is long. Right? And areas where conduction speed is slow, the refractory period is short. That happens due to electrical remodeling. We talked about the reasons yesterday. So now, what are the pathologies that can lead to this kind of heterogeneity, like the cardiac, the myocardium becoming heterogeneous? What are the pathologies that can lead to it? Now, one pathway, like there's a lot of pathways, like how a suitable, we call that the formation of a suitable substrate. Again, on the background so like the reasons for that I've also mentioned at the end of this document, like why a substrate capable of re-entry can be formed here. But there are two main reasons, like two main categories. First of them is like structural or anatomical reasons. So say so that can happen due to myocyte fibrosis, stretch, dilatations, and ischemia, scar formation. So like if there's a scar, say due to some previous myocardial infarction, so like the area of the scar itself, that is electrically silent. But the area in the periphery of the scar, like around the scar, that usually conducts impulses slowly. Okay, and the area beyond that conducts impulses normally. So therefore, that can also lead to heterogeneity in the cardiac, in the heart bone. Okay? So that is one way substrates capable of re-entry can be formed. And the other thing is it can also happen due to conduction abnormalities. Right? So things like ischemia, hypoxia, acidosis, electrolyte imbalances. These can also, through different mechanisms, I'm not going to go through every mechanism, but it's really good if you guys can go through each and every mechanism and figure out what exactly happens there. Okay? So, but due to pathological conditions like inflammation, ischemia, hypoxia, and and other electrolyte imbalances, that can also lead to the formation of heterogeneously conducting zones. We call this, this is a functional problem because the myocytes themselves are normal. Nothing has happened to them. But like their functions have been altered due to some kind of pathology. So this creates a functional substrate that is capable of re-entry. Things like scar formation and other sorts of things, dilatation, fibrosis, all of those things, they cause structural, like the formation of a structural substrate that is capable of re-entry. Okay, so those are the basic mechanisms, and the reasons for each and every one of them, it's good if you can go through them again. Anyway, so now we have a suitable substrate that has been formed. And so one area that is conducting slowly and has a short refractory period, another area which is conducting fast but has a long refractory period. Okay, so now our stage is set. Next thing is we need a trigger. Now a trigger is usually, lots of things can act as triggers, but basically most of the time the triggers can be either an EAD, a DAD, or a premature atrial. So like basically what can happen is this thing. So say something like this. So this is the suitable substrate. Now, if this is the suitable substrate, what can happen is an EAD can straight away lead to the formation of this one. A EAD or a DAD can act as a trigger. Okay, so I will draw it the other way. An EAD, sorry, an EAD or a DAD can straight away act as a trigger for this substrate. If if there is an area of if there's an area of heterogeneity near the area where the EAD or DAD was generated, so then that can lead to the formation, that can act as a trigger. Another thing that can happen, so this happens if the area of heterogeneity is close to the area where the EAD or the DAD was generated. However, now we talked about this as well. EADs or DADs can also lead to the formation of premature ventricular contractions or premature atrial contractions or a sustained tachycardia, sustained tachy. And so then you have beats being generated and they propagate across the myocardium. And now say once they are propagating, if they encounter if they encounter an area of heterogeneity, that can also act as a trigger. So EAD, DADs can directly act as triggers or indirectly via PVCs, PACs, or a sustained tachycardia. Another thing that can happen is that if there is abnormal automaticity, so you have abnormal automaticity. So this can also lead to premature beats. So like a beat coming before the sinus beat is expected to arrive. And so this can also act as a trigger for this re-entry circuit. So how exactly does the re-entry circuit develop? So this we also talked about earlier. So what happens there is you have, let me go through this one. Yeah, so you have, so now we have a trigger coming through. So what exactly are these triggers we talked about now? So now when this trigger comes, especially if this is a premature trigger, and so then what has happened is that the fast conducting zone is still refractory, but the slow conducting zone has recovered. So yeah, especially if this is a kind of thing. Now, say if both were say fast conducting zones, then both would be refracted. Then nothing would happen to this impulse; it would be blocked. But since there is one area of slow conduction with a faster recovery period, now this has recovered and it is capable of conducting. So it conducts, but it conducts very slowly. It conducts, but it conducts very slowly, and then ultimately it comes up to this point. Here you have an impulse going down. So the impulse bifurcates basically. And the other impulse, what happens is now this fast conducting zone has now recovered. And even though it has a long refractory period, it has now recovered. Now there is enough time for it to recover. Then what happens? Now this is able to conduct again. So this now starts conducting in a retrograde direction. Remember, throughout the cardiac myocytes, throughout the cardiac wall, propagation of impulses can happen antigradely as well as retrogradely. Because like the myocytes, when you take them, so if this is a myocyte, they have gap junctions on both sides. So they can be connected like this, and they have gap junctions on both sides. So impulses can flow down this direction or in this direction as well. So now this conducts in a refractory, in a retrograde manner, and it reaches this point. And then what happens is that you have this thing. You have this impulse going back up again. It bifurcates here as well and it goes back up. And the rest of it, what happens is now this slow conducting zone has recovered faster. Now this is able to conduct again, and then it starts going down like this again, and a loop is formed. That is basically how we have the formation of a re-entry circuit. Okay, so those are the basic principles of how arrhythmias are generated. Okay, nice. Now let's move on to junctional or AV nodal arrhythmias. So at the quarter, so basically what happens is there is some sort of abnormality involving the AV node and the proximal bundle of His. That is why it's called the junction. The junction here, that includes the AV node and the proximal bundle of His. Okay, yes. Now, let us go to this one. First of all, we have, no, before that. So what we have here is a junctional escape rhythm. So So basically, here there are, so involving the AV node, there are three abnormalities that can happen due to abnormal automaticity. First of them is the junctional escape rhythm. What basically happens there is, if due to some pathological reason, if the SA node stops working, and or if the impulse rate, if the rate of generation of impulses from the SA node dips below, let me copy this, dips below that of the AV node. So basically, AV nodal beat rate is at around 45 to 50. SA node is 60 to 100. Ignore the atrial muscle one, okay? Yeah, so I got it. If this goes below this, then what happens is AV node takes over as the dominant pacemaker of the heart. So then that is called a junctional escape rhythm. So basically then what happens is the heart starts beating at a rate of 40 to 60 or 40 to 50, like 45 to 50 or 40 to 60, yeah, same. At that rate, the heart starts beating when the SA node fails. The next step in that one, so here what has happened is basically the AV node is completely normal, that is doing its job, and this is physiological as in this is a safety mechanism, and AV node is completely normal. It takes over once the SA node has stopped working due to some reason. The next phase in this one is called the accelerated junctional rhythm. So junctional escape rhythm. The next in line is the accelerated junctional rhythm. What happens there is now we have a true pathology of the AV node. Then this leads to the intrinsic rate of the AV node going to that of the SA node or even above. Not exactly above, but going precisely to the rate of the SA node. So that happens. So here what happens is like, it's kind of like a dual pathology, okay? So basically there is, due to some pathology, an increase in the rate of the SA, of increase in the intrinsic rate of the AV node, combined with a slight decrease in the intrinsic rate of the SA node. Then what happens is that, so when both of these are combined, SA node dips and AV node rises up. Then what happens is that the AV node starts dictating the rate of the heart, and this starts beating at a rate of 60 to 100 beats per minute. That is basically the rate of the SA node. Basically, SA node, AV node SA node beat rate again, beat penta. This may occur due to digitalis toxicity. There's other reasons as well. So that here there's a combined pathology. Something's wrong with the SA node and something is wrong with the AV node as well. The next step in this one, that's not mentioned in here, but the next step in this one is junctional tachycardia. Junctional tachycardia. What happens there is a pathology of the AV node which leads to its intrinsic rate being higher than the AV node, higher than the SA node, being higher than 100 beats per minute. Here the SA node might be completely normal, but the AV node is pathological and that takes over as the dominant pacemaker. There might also be something that is affecting the SA node as well. That can happen here as well. But this can happen with a healthy SA node as well. So then that is called a junctional tachycardia. So there, the heart rate is more than 100 beats per minute. So you have the junctional escape rhythm going on to, so that is 40 to 60 beats per minute. So you basically, heart is at a bradycardia. Accelerated junctional rhythm, that's 60 to 100, then heart is at sinus rhythm. Junctional tachycardia, then that is a true tachycardia. Yes, so those are three basic mechanisms that can happen due to abnormal automaticity involving the AV node. So let's go through these junctional escape rhythms and let's go through the ECGs as well. Okay. So, like I said, so I'm going to make all of the reasons I've given methanemethian. So junctional escape rhythm. So basically, the junction escapes from the overdrive suppression of the SA node. So that can happen due to the SA node failing to fire, SA node impulses not reaching the AV node, or the SA node rate dropping below the intrinsic AV junction rate. So this leads to loss of overdrive suppression, allowing AV junction to take over AC. Okay. So mechanisms, all of these I've mentioned in here, but here these are the basic mechanisms. So One thing that can happen is sinus bradycardia. So that is excessive vagal tone. Sinus bradycardia and excessive vagal tone, both of them same. Now, an important point to remember here is that so the parasympathetic system affects the SA node more than the AV node. So when the parasympathetic stimulation is very high, the SA node is more suppressed than the AV node. So if this suppression is sufficient enough, sometimes the SA node rate can dip below that of the AV node, and then AV node will take over as the dominant pacemaker. Sinus arrest means that due to some reason, the sinus node has stopped working, and due to some pathology. Sinoatrial exit block basically means that the sinus node is working, but the impulse cannot be conducted from the sinus node. You can in the periphery, there's some sort of a block. And so sinoatrial exit block එක වගේ එකක් තමයි ischemia or fibrosis affecting the SA node. So ischemia can happen due to an SA nodal branch එකක් තියෙනවානේ. Right coronary artery is the SA nodal branch. So there something can happen on there. So එහෙම වුණොත් SA node will be blocked. එතකොට ඒකත් දැනගන්න, that's an important point. So you have basically left and right coronary arteries coming in, left coronary artery, right coronary artery coming along like this. Right coronary artery, it gives a branch up to the SA node, that's called the branch supplying the SA node. And there's another branch that comes down, that's called the conus arteriosus. Conus arteriosus is the one which supplies the AV node. Remember that both of them are supplied by the right coronary artery. And then another thing, drug effects. So you can basically things that suppress the SA nodal, that suppress the sympathetic activity. Basically, these are parasympathomimetics. So beta blockers, digoxin, calcium channel blockers, all of them, they can also act in the same manner as excessive vagal tone, right? And suppress the SA node more than the AV node, allowing the AV node to take over as the dominant pacemaker of the heart. Another key thing to remember is that junctional escape rhythm is protective. And junctional escape rhythm is protective. It's not pathological. Not pathological as there is a pathology with the SA node, but this is a physiological mechanism that is like a fail-safe. So this helps in preventing asystole. Asystole is that there is no impulse reaching the ventricles, and the ventricles stop beating and the heart stops pumping. Okay, so that is junctional escape rhythm. Now let's look at the this thing. What happens in the ECG? Now the first thing is in the ECG there will be a tachycardia. Let me get my this thing. So methanadi AV node has taken over as the dominant pacemaker. That sends signals down at a rate of 45 to 50 or 45 to 60. And then the heart beats at that rate. So therefore, this leads to first of all, a tachycardia. Now then, what happens to atrial activation? Now, the thing in here is, remember what I said earlier, the heart myocyte, the heart wall can be, the activation can be retrograde as well as antegrade as well as retrograde. So here what happens is that the AV node sends impulses that travel upwards as well. So that way, so basically what happens is at the same time, simultaneously, the ventricles and the atria are activated. So then what happens? Then what happens is, so the ventricular activation that is represented by the QRS complexes. So QRS complex will happen like this. And QRS complex usually atrium activate that is represented by the P wave, QRS. That happens before the QRS complex. But here what happens is that P wave because they happen at the same time. The P wave basically gets hidden inside the QRS complex because the QRS complex is much larger. Here, P wave is basically hidden inside the QRS complex. Sometimes, and the other thing, so that is one thing that can happen. And the other thing is, so sometimes maybe, so that is one possibility, or maybe the P wave can occur before the QRS complex, like atrial depolarization can happen slightly before ventricular depolarization. Then P wave will appear immediately before the QRS complex. Now, another thing is this P wave will not be something like this. because now all of this we are looking from lead to the eye, like the scanning electrode is here. So here, normally there's a positive deflection coming towards here. So therefore the P wave is a positive deflection. But here the impulse is going on the other side. The positive impulse is going on the other side. So therefore the P wave will not be like this. The P wave will be inverted. If it happens before the QRS complex, P wave will be inverted. And that is another abnormality that can occur. Or sometimes the P wave, like atrial depolarization, can happen immediately after ventricular depolarization. Then the P wave will appear immediately after the QRS complex, again inverted, so it will be something like this. So those are the basic things that can happen in this thing, in P wave. In junctional rhythms, what can happen is this. So there, you can have a hidden P wave, you can have an inverted P wave, and you can have a junctional rhythm with P waves after the QRS. But then again, this is wrong. They say here, P wave should be something like this. So you have sorry. So you have QRS complex. So you have the QRS complex here. QRS complex is here. And P wave is here, but P wave happens here. This is the P wave, and this should not be like this. It should be an inverted P wave. Okay. So that is basically what happens in there. QRS, maybe the QRS is like this. P happens like that. So that is the ECG pattern. Now, what is the consequence of this? Now, one thing is, so here what happens is the atrial contract. Now, basically, atrium and ventricles are contracting at the same time. Then what happens? So usually atrial contraction precedes the ventricular contraction. So there will be, in the normal physiology, there will be something called the atrial kick, like the contraction of the atrium after passive filling will contribute to about 15 to 30% of the filling of the ventricles. So now this thing will be lost. Then what happens? Then what happens is that, so now this kind of filling, this kind of atrial kick is especially important in elderly people and people with diastolic dysfunction. Basically, people whose ventricles can't relax, they rely on this atrial kick. And again, LV hypertrophy, that also is a kind of a diastolic dysfunction. So then ventricle contract and atrium contract at the same time. Ventricle contraction forces are much more powerful than atrial contraction forces. So valve, tricuspid valve that closes. Then what happens is that atrium contract when this blood will remain and it won't come into the ventricles, and ventricular output will be low. That is basically, that is the hemodynamic consequence of this. So there are others you can read, but this is the basic mechanism of this one. Okay. These are some things I wanted to search a little bit more, but keep that. Next thing is accelerated junctional rhythm. So that is basically, there's some kind of SA node pathology combined with some pathology increasing the rate of the AV node, allowing it to come to a sinus rhythm level. So what happens here? So enhanced AV junctional automaticity can happen due to increased calcium currents, decreased outward potassium currents, or vagal braking, excess sympathetic tone. Again, mechanisms, I didn't have time to go through each and every one of them. But ultimately what happens here is that sinus node loses dominance and the AV node automaticity goes up. Now this is an important one. Role of myocardial injury and ischemia because this is clinically important. So this thing. So ischemia of the tissues supplied by the right coronary artery, which also supplies the AV node, which supplies the AV node. So then what can happen is that when there is ischemia like that, this can lead to local acidosis, catecholamine excess, and membrane instability. And these injury currents apparently increase the automaticity of the junctional tissue. So therefore, So this can happen in inferior MIs. This can happen because inferior MI, again, that is supplied by the right coronary artery. So they've got, most people are right dominant people, and inferior MI, that usually happens due to right coronary artery dysfunction. They've got and post cardiac surgery, so that can be a CABG or valve surgery, basically something involving the tissue around the atrioventricular node. This can lead to the automaticity of the AV node being higher. So so then right coronary artery, this conus arteriosus supplies the AV node, and this supplies the SA node. So the inferior may hari occum supplied by the right coronary artery. Okay, so there's also these drug-induced mechanisms, autonomic imbalances, electrophysiological consequences, all of that is there. Then methanadi, what will the ECG be like? ECG basically will be like this. So again, abnormalities of the P wave is always inverted, but it can immediately precede the QRS complex, like very close to the QRS complex, or it can happen after the QRS complex. Maybe sometimes can be merged with the T wave as well, so you won't even see a P wave. And or it can be merged within the QRS complex itself, and you won't see a P wave. So all of that can happen. But the difference from junctional escape rhythm is now this happens at normal sinus rate. The rate will be 60 to 100. Rate will be 60 to 100. And now the pathologies we talk now, those are the same things which lead to the formation of junctional tachycardia. Basically, if those pathologies happen in a more severe way, this can lead to a junctional tachycardia. But this is an important one. Another thing that can happen is that we told that accelerate in accelerated junctional rhythm. So this is SA and this is AV. So let's talk about it like this. So there's SA node and there is AV node. There is junctional escape rhythm. There is accelerated junctional rhythm. And then there is junctional tachycardia. So the junctional escape rhythm, the SA node is always pathological. Right? AV node is usually normal. Right? AV node is usually normal. It just takes over the heart rate. In accelerated junctional rhythm, usually SA node is buller, but it can be normal as well. But AV node is definitely pathological. Then you have the junctional tachycardia. In junctional tachycardia, most often the SA node is usually normal. It's just that there is some pathology with the AV node. So during these, so accelerated junctional rhythm and junctional tachycardia, SA node can be normal. So the SA node can continue to fire independently of the AV node. Basically, then what happens is that atria contract according to the SA node and the ventricles contract according to the AV node. Whenever. So that leads to something called atrioventricular dissociation. So what happens there is junctional impulse activates the ventricles. Sinus node may continue firing independently. Atria and ventricles are electrically independent. This leads to what is called variable PR relationships, because P wave is the atrial depolarization, R wave ventricular depolarization. Okay? So that there can be a dissociation. Most important one is this can lead to what is called Cannon A waves. Cannon A wave is something you see in the jugular venous pressure, the JVP curve. It's a phenomenon that you see in the Cannon A wave. So basically what happens there is this. So now ventricle goes at one rate, atrium beats at a different rate. So now when they're beating like this, say it comes to a point where they synchronize as in one of their beats synchronize. Atrium is contracting, ventricle is also contracting. Ventricular forces are much higher. This leads to valve closure. No matter how hard the AV node, the atrium tries, it can't open this valve. Then what happens? So then the atrium is compressing against a closed valve. Therefore, what happens to this pressure? And this pressure has nowhere to go except for along the SVC and the IVC. Back pressure now, obviously, we can't see what's going inside. AV in the IVC, that's in the thoracic cavity. But SVC, we can see through the jugular vein. And JVP curve, again, we can see what's wrong with the right atrium. We can see. There, what happens is that the pressure will rise up massively because this pressure will be transmitted along this jugular vein, and this will lead to a huge spike in the JVP curve. That is what we call a Cannon A wave. Right? So you have, this is what you call a Cannon A wave. Normally, you have normally amplitude Cannon waves are huge. Right? So that is basically what happens there. Important stuff. Right. Then we go to this thing, two important ones, AV nodal reentrant tachycardia and AV reentrant tachycardia, including Wolff-Parkinson-White syndrome. Here what happens is basically you have the formation of a reentrant circuit. And කලින් කතා කරපු AV node දේවල්, those happen due to abnormal automaticity. These things happen due to these ones, reentrant circuit formation. What happens? So in AVNRT, what happens is basically like this. Now, so AVNRT is the prototype of this reentrant tachycardia. So let's see what happens there. Now, when you take the AV node, a certain percentage of people, like 20 to 30% of people have AV nodes with dual pathways. These they have naturally fast pathways and naturally they have a natural fast pathway and a natural slow pathway in the AV node. This occurs naturally in 20 to 30% of people. Then what happens? So you have conditions fulfilled when zones fast pathway which has rapid conduction and long refractory period, slow pathway with slow conduction and slow refractory period and short refractory period. Then what happens is in some people, can make 20 to 30% of people when they reach adolescence, this phenomenon doesn't happen during infancy, but when they reach adolescence, again, basically during infancy, AV node usually normal homogeneous. But if you are predisposed to this, by the time you reach adolescence, this heterogeneity within the AV node itself, these conditions mature during adolescence, not during infancy. What happens there? There is increasing heterogeneity of conduction and refractoriness when you mature with age, and a greater separation of fast and slow pathway properties. And when you reach adolescence, autonomic nervous system becomes highly labile as well. You have a high resting vagal tone, which prolongs the fast pathway refractoriness, apparently, right? And strong sympathetic surges, such as stress, exercise, caffeine. You start taking caffeine in adolescence. And stress you usually start getting during adolescence. You start exercising during adolescence. So you have these strong sympathetic surges. These apparently shorten the slow pathway refractoriness and speed conduction. Basically, these widen the timing window required for re-entry. So in these people, so you have a vulnerable population of 20 to 30 people, and the minority, even like a small minority, even out of them, they are when they reach adolescence, they are fast and slow pathways, like the AV node becomes very heterogeneous. So this happens in a minority of the population. Basically, you now have a suitable substrate for re-entry. එතකොට දැන් හිතන්න මේ වගේ කෙනෙක්ට if they also get something like a premature atrial contraction. Now, premature atrial contractions, they are benign, usually benign, and usually people do get them. Right? So if there is a transient electrolyte imbalance, yeah, people can get PACs, but usually that's benign. This doesn't do anything to people. But they are so someone who is genetically predisposed to this one, and is in adolescence වගේ කියන්නේ මෙන්න මේ විදිහට enough maturation happen වෙලා තියෙනවා නම් ඒ වගේ කෙනෙක්ට පැක් එකකුත් આવොත් හරිනේ premature atrial contraction එකක් આવොත් මෙන්න මේ conditions fulfill වෙනවා fast pathway still refractory slow pathway as recovered and එතකොට වෙන්නේ මොකද්ද මේ විදිහට you have the formation of a reentrant loop ඒගොල්ලන්ගේ reentrant loop එකක් එනවා. And apparently, and this is also out of the arrhythmias, apparently this is a kind of a common one. Not common among the population, but out of arrhythmia cases, this is a pretty common one, apparently. So basically, that is what happens. Mechanically, you have an abnormally fast running circuit developing in the AV node going along like this. So it sends signals up. Let me put this in a different color. Right. So you have an abnormal circuit running in the AV node like this. Right. So this sends signals up and this sends signal down. Right. So this rate, right, what is this rate? Usually it's at around, as I remember, I have written this somewhere. How did I write this? As I remember, this AV nodal rate is at around like 200 vage rate as I remember. Can't find it. But anyway, you have this sort of reentrant loop running within the AV node. Then what happens? So therefore, this kind of behaves pretty similarly to a junctional tachycardia. Now, junctional tachycardia is happened due to abnormal automaticity. This is happening due to this thing. Reentrant circuit. So what are the different things that can happen? What you can have is again, that methanadi. Now, this is completely normal. Let me put this one and paste it here. The methanadi, the bundle of his and everything is pretty normal. So basically, everything below the ventricles below the junction is normal. This part is entirely normal. So therefore, conduction along that pathway happens normally. Ventricle contraction happens normally. It's just that the rate is fast. Other than that, not everything is good. So therefore, your QRS complex is narrow. Narrow as in that is normal. That is less than 0.12 seconds. And then another, so basically what you will have is a narrow complex tachycardia. And you will start having a narrow complex tachycardia. And another thing is, now this is now another thing about AV and RTC is the rate is very regular, right? Because this doesn't happen due to electrolyte abnormalities and stuff. This happens due to some sort of structural issue. This electrical circuit that is looping in the AV node, that is a very stable one. Therefore, you have a regular narrow complex tachycardia going on. What happens to the P wave? Again, pretty similar to junctional tachycardia because atrial and ventricular contractions happen at the same time. So therefore, the P wave can usually be hidden within the QRS complex. That is what is shown in here. Another thing that can happen is that the P wave can be seen in the QRS complex. That can be seen in the QRS complex, but as a pseudo S wave. So this is QRS. The P wave can happen somewhere along here when the pulluwa. An inverted P pulluwa, similar to a junctional tachycardia. But let me search the actual rate of AVNRT. What is the rate of beat rate? Sorry, of AVNRT Yeah, 150 to 250 beats per minute. So the average here is at around 200. Junctional tachycardia එකක usually it's just like 120 130 වගේ rates වල තමයි යන්නේ. Stenotic එකට වඩා වැඩි, but not too high. But මෙතනදී this goes at around a rate of 200 වගේ rate එක යනවා. එහෙම යද්දී you usually don't get a separation of the QRS and P waves. P wave එක ගොඩක් මේ විදිහට it comes backwards. Backwards ඇවිල්ලා it usually gets merged along with the QRS wave. එතකොට කියන්නේ දැන් හරියට merge වෙනවා. මෙහෙම සමහර වෙලාවට පොඩ්ඩක් පරක්නවා. If the beat rate is a bit low at around 150 වගේ දෙද්දී maybe මෙතන තියෙන S wave එකේ superimpose වෙලා තියෙන්න පුළුවන්. ඒ කියන්නේ normal QRS එක කියන්නේ then QRS මෙහෙමනේ යන්නේ. මෙහෙම තියෙන එකට you have the merger of an inverted P wave as well. එතකොට finally the S wave will start looking something like this. So we call that a pseudo S wave එකක් කියනවා. A pseudo S wave will be in lead 2. lead 2 කියලා කියන අපි heart එක දිහා මෙතනින් බලන්නේ. That is what will happen in lead 2. පස්සේ ඊළඟට so that is what you see. So that in inferior leads and V1 lead එක V1 කියලා කියන්නේ මේ විදිහට heart එක දිහා බලන මේ හරියෙන් වගේ බලන lateral lead එක තමයි V1 කියලා කියන්නේ. So what will happen in V1 එතකොට එතනදිත් උතන දැනගන්න ඕන දේ තියෙන්නේ මෙන්න මේක. So the explanation I've given in here, okay? Explanation is in here. Basically what happens there is this. So the atrial activation, if the atrium is like this, normally activation happens from superior to inferior and from anterior to posterior. So no, sorry, anterior to posterior tama activation එක වෙන්නේ. So එතකොට the මෙන්න මේක. එතකොට that is usually how it will happen. එතකොට now lead V1 හරිනේ. එතකොට lead V1 එකේ V1 එක කියලා කියන අපි මෙහෙම බලන එක, that is ඒ කියන්නේ heart එක දිහා laterally බලන එක. When we look at that, since the atrium is depolarizing from anterior to posterior, the electrical impulse is moving away from lead V1. Therefore, we will see that as a negative deflection in the R in V1. But in AVNRT, what happens is everything is reversed. Atria depolarize from inferior to superior. I mean, they depolarize inferior to superior and from posterior to anterior. Posterior to anterior. Now what will happen in lead V1? You will see that as a positive deflection. Then lead V1 usually again this happens after lead V1 usually QRS complex tiny thing එකක් තමයි තියෙන්නේ. එතකොට දැන් මෙතනදී lead 2 වල වගේම මෙතන this P wave will also be superimposed into the latter phase of the QRS complex, especially if it's a slow AVNRT. Fast QRS complex but that will be superimposed in there. Then what will happen is that මෙන්න මෙතනදී මෙන්න මේ හරියට superimpose වෙනවා on ඔය කිව්ව P wave එක. එතකොට මොකද්ද වෙන්නේ? Finally the final result will look something like this. And we call that a pseudo R dash wave in V1 කියලා කියනවා. That is basically another change which you will see in the ECG. And okay. Yeah. So basically that is what will happen in this thing. AVNRT basically that is what will start happening. So that's what happens in a typical AVNRT. Atypical AVNRT කියලා කියන්නේ basically mechanism is something like this. Again, antigrade conduction is slow, retrograde conduction is fast. So yeah. So again, so that is the typical one. And atypical it's reversed, I think. I'm also not exactly very sure about the mechanism, but I think it is different. But here in atypical AVNRT, PVF apparently happens before the QRS complex. So exact mechanisms again, I'm not very sure. But then again, I don't think we don't need to know this because you're going to become a cardiologist, I think. Yeah. And so that is basically what you will see. ඊට පස්සේ and we'll also go through that flowchart algorithm as well. Okay, remember. Tell me. Well, let's go through that as well. All right. That is basically what happens in AV node. In AV NRT. Another interesting thing, like, so what is the treatment for this one? So now the definitive treatment, if drugs fail, we will talk about that as well later. So if drugs fail, what you do is so this is the slow pathway, this is the fast pathway. You can send a catheter up the inferior vena cava, and you can ablate, you can destroy these myocytes in the slow path. And so then what happens? So you call that catheter ablation, right? So then only the fast pathway remains, and therefore impulse conduction happens only along the fast pathway. So selective ablation, selective catheter ablation of the slow pathway, that is the definitive cure for AVNRT. After that, AVNRT won't happen. And okay, so that is one thing you need to know. Then we go on to this one, Wolff-Parkinson-White syndrome and atrioventricular reentrant tachycardia. Now, so how exactly are these two terms like related to each other? Atrioventricular reentrant tachycardia and Wolff-Parkinson-White syndrome. All right. So here again, what happens is you have the development of a macro reentrant circuit. Right? So let's go through what happens in there. Basically what happens is this. This. So usually there is no muscular connection. Maybe the myocyte swelling, or there is absolutely no, in a usual person, there is no electrical connection between the atria and the ventricles through normal cardiac myocytes. Normal cardiac myocytes, there is absolutely no electrical connection between the atria and the ventricles. The only connection that is there is through the bundle of His. That is a conduction tissue connection. That is the singular connection between the atria and the ventricles. Because valve and uterus, those are fibrous connections. So separate atrium from the ventricles. Atria and ventricles are electrically independent. That is basically what it means. So therefore impulse conduction happens only along here, and impulse conduction spreads along like this. Now Wolff-Parkinson-White syndrome is a condition, that's a congenital condition where you have an abnormal muscular connection, myocyte swelling connection between the atria and the ventricles. So usually it happens in the left atrium. That happens in, as I remember, that is the most common one. Exact percentages I don't remember, but this is called type A Wolff-Parkinson-White syndrome. Type A WPW. You can also have an abnormal connection here. You can have an abnormal connection in this thing. Sorry. Again, you have an abnormal connection. You can have between the right atrium and the right ventricle, and this is called type B Wolff-Parkinson-White syndrome. So that is so basically that's a syndrome. That's a congenital condition where there is an abnormal muscular connection between the atria and the ventricles. This can lead to a type of arrhythmia called atrioventricular reentrant tachycardia. Basically, that is what happens in there. So let's go through this mechanism. What is going to happen? Now, let me get another pen. So another thing, maybe the bundle, there's a specific name for it, that is called the bundle of Kent. So this is called the bundle of Kent. That is a name you need to remember. Remember, so that is apparently present in 0.1 to 0.3% of the population. ඔතන වෙන්නේ මොකක්ද? මෙන්න මේ වගේ දෙයක්. How shall I explain this? Antidromics and orthodromic එක වෙනවා. Give me a second. Try to find a way to explain this properly. Alright, ඉතින් බලමු. So එතකොට දැන් මෙතන තියෙන මෙන්න මේ වගේ එකක්. So then මෙතන electrical impulse එකක් එන්න ගත්තාම, so you have an electrical impulse coming from the SA. Let me change my color. So you have an electrical impulse which is coming from the SA node. Exactly. Yeah, you have an electrical impulse coming from the SA node. This spreads throughout the atria. Spreads throughout the atria like this. So now it reaches the SA node, and if you have Wolff-Parkinson's white, it reaches this place. The SA node and you have reached the bundle of Kent as well. එතකොට මෙතනදී මෙන්න මේ විදිහට re-entry circuit එක establish වෙන්න යන්නේ. How exactly does that happen? මෙතනදී now the AV node, එතකොට when you, so basically දැන් මෙතන තියෙන්නේ myocytes. Okay, so you have contractile tissue here. Contractile tissue. Metana AV node you have conduction tissue. Conduction tissue එකක් තමයි තියෙන්නේ. So when you compare them, what happens is that the AV node usually has slow conduction and a slow refractory period. Basically, AV node, relative to the cardiac myocyte, functions as a slow conduction pathway with a shorter refractory period. Basically, that happens because of this one. Depolarization spike again. L-type calcium channels SA node again. Therefore, the spike, the slope is lower compared to the cardiac myocytes because they have in sodium channels. Sodium channels, there's a faster spike. So these conduct impulses and fast, but yeah, so relatively slow conduction. Okay. So if you compare them, you have a AV node which has a slow conduction and therefore a shorter refractory period, and the accessory pathway or the bundle of Kent which has fast conduction and a longer refractory period. Again, re-entry circuit then establish when now the slow pathway has recovered faster. Therefore, the impulse passes through the AV node. Metanadi, fast pathway, it's still refractory and this is blocked. So the methanic impulse then impulse it reaches the bundle of Kent retrogradely and above. Then by the time it gets to here, this pathway has now recovered. So then conduction can happen retrogradely along the bundle of Kent. Let me change this one here. Conduction happens retrogradely along the bundle of Kent. Then this starts spreading across the atrium. And the impulse starts spreading across the atrium. And usually, and ultimately it reaches the SA node. It also resets, it reaches the AV node and it resets the SA node as well. And SA node because usually this rate is faster than the SA node. SA node reset this takes over as the dominant pacemaker. AV node is a slow conducting zone, but it has recovered faster and therefore the impulse can again go down. And the cycle will start repeating. You have the generation of a macro re-entrant circuit. A macro re-entrant circuit form SA node loses its dominance because the rate of this one is much faster than the beat rate of the SA node. Typically, the rate will be at around 150 to 250 beats per minute per rate developed whenever. So that is basically what can happen in Wolff-Parkinson White syndrome. Then okay, there's a few other nuances we need to talk about as well. You have two types basically. Percentage as well. ඒකෙන්ද usually Wolf Parkinson White එකේ මෙන්න මේ විදිහට anti clockwise හරිනේ anti clockwise තමයි you have the circuit running around. So this is called orthodromic. This is called orthodromic AVNRT එකක් කියලා කියනවා. This is what happens in a majority of Wolf Parkinson White people. You have an orthodromic circuit running around. එතකොට what will be the ECG pattern in here? එතකොට ECG pattern එක ගත්තාම වෙන්නේ orthodromic AVRT එක because here then මෙන්න මේ circuit එක දැන් අර මම උඩ යන circuit එක that's this one. So here the ventricles are normal actually. Like මෙතන පොඩි බුලක් තියෙනවා but other than that the ventricles are completely normal. His Purkinje system is good, ventricular myocytes are good, nothing bad going on in there. So what happens is that then you have a normal QRS complex එකක් normal විදිහට තියෙනවා. The QRS complex will be narrow. There will be a narrow QRS wave. පස්සේ ඊළඟට now the P wave හරිනේ දැන් මෙතනින් දැන් මේ විදිහට ගිහින්න පස්සේ atria එක activate වෙනවා. So you will have a retrograde P wave. හරිනේ retrograde P wave එකක් තියෙනවා. So you will have a retrograde P wave එකක්. ඒතකොට P wave එක retrograde කියලා කියන්නේ that will be an inverted P wave එකක් happening after the QRS complex. So you have the QRS complex running along like this and then you have an inverted P. පස්සේ මේ තියෙන්නේ P wave එක QRS P T. ඔන්න විදිහට තමයි pattern එක යන්නේ. So that will be a retrograde P wave after the QRS. No delta wave කියන එකට ඊළඟට එන්න. And so basically that is the ECG pattern you will get in a orthodromic AVNRT. And so it got inverted P wave often after the QRS complex. So this will happen immediately after the QRS complex. So you have the QRS මෙතන තියෙන P. එතකොට දැන් මෙතනදී there's no PR interval because P happens after QRS. So now you have what is called an RP interval. RP interval that usually AVNRT causes a short RP tachycardia. Again, short RP interval tachycardia. P wave happens immediately after the QRS complex. So AVNRT usually has a short RP tachycardia. The next thing we have to talk about before we go on to antidromic AVRT is there's another phenomenon called pre-excitation. Pre-excitation is usually something that happens before an orthodromic AVRT develops. Orthodromic AVRT එකක් හැදෙන්න කලින් වෙන දෙයට වෙන phenomenon එකක් තමයි pre-excitation කියලා කියන්නේ. What happens there is this. So you have these impulses generated from the SA node going across the atria. මෙතන Wolf Parkinson White අර bundle of Kent එක මෙයා පෙන්නලා තියෙන මේ තත් it's in the right side. තමයි මේ රූපේ පෙන්නලා තියෙන්නේ. එතකොට now AV node is slow. එතකොට ඒක හින්දා and but it has recovered faster. Okay, but it has recovered faster. Slow impulse conducts along like this. මෙතන මොකද්ද වෙන්නේ? මෙන්න මේ වගේ එකක් වෙනවා. දැන් මෙතන දැන් මේ myocytes වලිනුත් how can I explain this? So the AV node has slow conduction එකක් තියෙන්නේ. So that is conducting. ඊට පස්සේ yeah, එතකොට මෙතනදී වෙන්නේ basically pre-excitation කියලා even though again then so this is the slow pathway so which has recovered which is non-refractory then this is the fast pathway which is still refractory කියලා අපි ඉගෙන ගත්තේ. But the thing is then මේ හරියේ there can be a certain amount of slow conduction happening. Yeah, how can I explain this in a good way? Yeah, මෙතනදී a point that I forgot to mention මෙන්න මේක. This thing. Then මෙතන this connection. Sorry, I forgot to mention this earlier. මෙන්න මෙතන මං කියවනේ, so there is this bundle of Kent කියලා. So this muscular connection that is usually අර Purkinje fibers වලම extension එකක් වගේ තමයි තියෙන්නේ. So එතකොට ඒ කියන්නේ so those are not typical cardiac myocytes but conduction tissue. එතකොට another thing you have to know is that මෙන්න මේ conduction system එකේ දැන් ඔය mainly SA node එකයි AB node එකයි proximal bundle of His එකේ වගේ තමයි මෙන්න මේ වගේ action potential එකක් දුවන්නේ. In the bundle, in the distal bundle of His and in these Purkinje fibers, ඒවත්තට මෙන්න මේ වගේ cardiac myocyte එකක් වගේ action potential එකක් තමයි ඒව usually දුවන්නේ. And so එතකොට yeah, so that is one point to keep in mind. And so those are again re-entry loop එක හදන්න form වෙන්නේ ඒ කියන්නේ contribute වෙන්නේ මෙන්න මේ වගේ මේ type එකකට තියෙන like මේ වගේ so cardiac myocyte type එකේ තියෙන conduction tissue වල තමයි ඔන්න ඔය bundle of His එක හැදිලා ඔන්න ඔය conduction එක run වෙන්නේ. But along in that pathway you have regular normal cardiac myocytes as well. You have these regular normal cardiac myocytes. So you have that in the middle of that bundle of again. So if you take the bundle of Kent, you have these Purkinje fibers වගේ system එක මේ විදිහට run වෙවි තියෙනවා. But here you have these cardiac myocytes මෙන්න මේ විදිහට normally තියෙනවා. එතකොට then what happens? So එතකොට මම ඔය කිව්ව කලින් ඔය refractory වෙලා තියෙන Arrhythmia that mainly applies to this thing. මෙන්න මේ වගේ Purkinje system එකේ තියෙන phenomenon එකෙන් හිතාගෙන යන්න ඕනේ. Purkinje system එකේ තමයි මම අර කිව්ව මෙන්න මේ property එක තියෙන්නේ. ඒ කියන්නේ AV node එකේ slow conduction, shorter refractory period, accessory path එකේ fast conduction, longer refractory period කියන phenomenon එක තියෙන්නේ. හරිද? මෙතන තියෙන ඔන්න ඔය Purkinje fibers වල තමයි ඔය system එක predominantlyම තියෙන්නේ. එතකොට හැබැයි එතකොට ඔන්න ඔය විදි due to that reason you have the formation of that circuit. එතකොට say now before that circuit forms හරිනේ ඔන්න ඔය circuit එක form වෙන්න conditions and the culling, so you have this bundle of Kent, you have the Purkinje fiber going through that and you have these cardiac myocytes as well. So now action potential reaches these cardiac myocytes. ඕක reach වුණාම now these cardiac myocytes can conduct as well. Now they conduct at a much slower rate than the Purkinje fibers, and 6 times lower than that. However, they have a certain amount of conduction capability as well. එතකොට මොකක්ද වෙන්නේ? මෙන්න මේ විදිහට now දැන් මෙයා so this conducts 6 times faster. And මෙයා 6 times faster conduct කරගෙන එද්දී මෙයාත් slowly මෙන්න මේ portion එකේ ventricle එක the portion of sorry shifted to single. So like the portion in here, the portion of the ventricle in here, that is also slowly depolarizing on its own. So then ventricular repolarization that has already occurred again then. So you have the PQRS then T wave එකත් වෙලා මෙන්න මේ මෙතන තියෙන sorry T එකත් ඇවිල්ලා next P wave එක හරියදී වෙන දේවල් තමයි අපි ඔය කතා කරගෙන යන්නේ. එහෙම කතා කරගෙන යද්දී now එතකොට මේ cardiac myocytes they are all good, they can conduct, right? So ඒකින්ද they also start conducting impulses retrogradely down this direction. So this conducts 6 times faster, this conducts at one speed. Right? So එතකොට so you have the ventricles being excited or depolarized from two sides. Right? So that is what you call pre-excitation කියලා. So එතකොට then pre-excitation, so basically pre-excitation is a phenomenon that develops before you have the development of the orthodromic AVRT. So yeah, so that is pre-excitation. එතකොට pre-excitation එකේදී what will happen is that an ECG, how will that manifest in an ECG is like this. So now normal, then another thing we need to talk about, this thing. How exactly then now with that we are going now that we are slowly starting to talk about ventricular problems about this one. So then ventricles already, I think I had a good explanation for that one. Ventricular tachycardia, I think I had. Give me a second. Why exactly does something become narrow complex and the other so a question we need to discuss now is why is the normal QRS narrow? Now so the impulse, so it goes through, let me get a good picture of the heart. And so the impulse normally it races through the His-Purkinje system. Now, therefore, the Purkinje fibers, they deliver the impulse almost simultaneously to the septum, to the apex, and the left and right ventricular endocardia. And then what happens is that millions of these myocytes start depolarizing together. And so, then what happens? So, basically then again the methanoning, you give the impulse to the myocyte. And methanoning, you give the impulse to a myocyte, and then this myocyte gives to the next myocyte, and ventricle depolarize vegan. Now this is at 6 times speed. This is at times 1 speed. However, even though conduction within the myocardium is slow, even though conduction within the myocardium from myocardial cell, from myocyte to myocyte, even though that is slow, it starts everywhere at once because the His-Purkinje system races along giving this signal. And may set depolarize vegan. Depolarize vegan. Another set starts depolarizing like this. Their depolarization speed is slow. However, His-Purkinje system the impulse conduction system impulse it races along giving this signal. So that's why even though conduction within the myocardium is slow, it starts everywhere at once. Result is a short depolarization time resulting in narrow QRS, because everything starts within a very short period of time. The entire ventricle starts depolarizing. Now say you have something abnormal, His-Purkinje system bypass කරලා His-Purkinje system bypass කරලා හිතන්න මේ හරිය දැන් මේක මම කතා කරන්නේ PVC එක ගැන කතා කරද්දී but can happen in anything basically. So if due to some reason an abnormal impulse is conducted along the ventricular myocytes like this, bypassing the His-Purkinje system now. එතකොට මොකක්ද වෙන්නේ? These will have to go from cell to cell. Then maybe they may උදව් කරන්න His-Purkinje system එකක් නැහැ. It doesn't flow along the His-Purkinje system. They go from ventricle, ventricle myocyte එකට යන්න. That's why. See, impulse begins in one patch of ventricular myocardium. And no rapid distribution system initially. That is the His-Purkinje system. Therefore, the wavefront must crawl cell to cell across the ventricle, and therefore the large areas activate late. The result is prolonged depolarization resulting in wide QRS. So the QRS complex wide that automatically means you have an impulse that is going to the ventricular myocytes bypassing the His-Purkinje system. And wide then it should have been narrow like this. Narrow it conducts normally through the His-Purkinje system, and usually that means it's not a ventricular arrhythmia. usually supraventricular arrhythmias tama narrow complex way. Ventricular arrhythmias, usually problem starts within the ventricular myocytes, and once that happens, the impulse starts spreading from ventricular myocyte to myocyte, and that leads to the formation of large QRS complexes. Now let's go back to our scenario. Wolff-Parkinson-White eකට අපි යනවා. Now when you go to the Wolff-Parkinson-White, this one, sorry. Yeah, Wolff-Parkinson-White එකේ now remember when I said talked about this thing මෙතන pre-excitation කතා කරද්දී now pre-excitation දැන් now මෙතන වෙන්නේ මොකක්ද දැන් pre-excitation එකේදී so you have this impulse going from the මෙතනින් එන එක now the His-Purkinje system may hari it's refractory, it is not working because that is the fast pathway compared to the AV node, which is the slow pathway, and therefore AV node conduct vela then මෙයා මේ විදිහට His-Purkinje system එකදී මෙහෙම race වීගෙන it comes racing along like this. However, the මේ හරිය වටේ තියෙන myocytes වලිනුත් you have the conduction of the impulse that starts going down slowly like this, and මේ විදිහට slowly impulse එක conduct කරගෙන යනවා මෙන්න මේ ventricular portion එකේ. So you have two depolarization vectors, this vector coming along from here and a small vector coming along from here, both which are seen from lead 2. එතකොට usually making එනවා නම් තමයි you see that as a nice narrow complex QRS complex එකක් විදිහට. මෙතනදී since you have another depolarization vector that also gets merged into the QRS complex and it becomes something like this. Basically what you have, we call this a delta wave කියලා. Delta wave formation එකක් එනවා. So you have so that normally it should have been something like this. So let me write this. So normally P wave should have gone like this. P wave, then Q R QR වගේ යනවා. So sorry. That is how it should normally go. But here what happens is that since there's another depolarization vector that also gets merged into this one, and the Q wave disappears and you have the formation of a delta wave. Now this delta wave now becomes pretty much close to the P wave. Sometimes it can even be merged with the P wave, but anyways that leads to the reduction in the PR interval. In this case, you can't even see the PR segment. So that is basically what pre-excitation is. එතකොට දැන් මෙතනදී ඔය pre-excitation එකෙන් පස්සේ තමයි you have මේ විදිහට එද්දි අරක මේ so now by this time this thing has recovered මේ හරිය His-Purkinje system has recovered and මෙයා උඩට ගිහිල්ලා you have the formation of a reactive circuit. ඔතනින් පස්සේ පටන් ගන්නවා you have your orthodromic AVRT එක පටන් ගන්නවා, but before that develops you have something called pre-excitation. But remember, orthodromic AVRT, that thing is gone. Maybe the pre-excitation things don't happen because maybe now you have the complete circuit going along. Then you again have a narrow complex QRS again you start getting because everything now flows normally along the His-Purkinje system, albeit at a very high rate. Still, there is no merging of other wave fronts coming along. There's no other vector coming along. Therefore, what happens is that you have a narrow complex happening in the orthodromic AVRT, and you don't have a delta wave in here. Okay. ඊට පස්සේ there is another thing you have again basically method in orthodromically if it starts happening along the other way that is called an antidromic AVRT. So antidromic AVRT එකක් කියලා කියන්නේ basically the circuit starts running in the other direction. Antidromic AVRTs are kind of rare, right? But yeah, basically there what happens is maybe the circuit starts going in the other side. Another thing is methana this is actually a little bit wrong because methanadi again the QRS complex will become abnormal because again the methanadi so now the normal QRS complex develops like this so this will look abnormal because this is going in the opposite direction. And so there will be some abnormalities in the QRS complex. Again, P wave wicket, there will be abnormalities. There will be an inverted P wave. That will happen usually immediately after the QRS complex. The QRS complex itself is abnormal. So therefore, this can also lead to something resembling a delta wave, which we saw in pre-excitation. But this is not really a delta wave. So that's why this delta wave may or may not be present here. The wide Q, and again, QRS complex will be wide, but this is not exactly a delta wave. It kind of looks similar to a delta wave. So yeah, so basically that is, so you have a wide QRS complex with a delta wave, which may or may not be present because that is not a true delta wave. It looks like a delta wave because you have the merging of the P wave and you have an abnormal QRS complex because that's going retrogradely. P wave is rarely seen, that is merged with QRS most of the time. And if P wave is visible, it is retrograde, yes. And occurs just before QRS that is wrong. Actually, it happens after QRS, right? Yes. Okay, so මෙතනත් පෙන්නලා තියෙන ඔන්න ඒ වගේ delta wave එකක් තමයි පෙන්නලා තියෙන්නේ. So delta waves are usually a sign of pre-excitation, but they can also appear in antidromic AVRTs. Usually not, and they definitely don't appear in orthodromic AVRTs. Okay. And so, okay, so that's basically what happens in there. Method of Wolf Parkinson White again, I've given a separate one. But yeah, basically that's what happens in there. Another thing that can happen is this one. Another important scenario we need to talk about. I hope that was clear. I give a point here because I think I kind of over-explained, not over-explained, but I feel like. But I hope you guys understood it, at least the basic principles of it. Yeah. So another thing that we need to know about is what happens if there's atrial fibrillation and Wolff-Parkinson-White. That's a nightmare scenario because then what happens is that, so now let's look at this one. So then methanadi, what happens in atrial fibrillation? You have multiple ectopic foci within the atria giving out these signals throughout the atria. And the atrioventricular node gets bombarded with different signal morphologies coming from these ectopic foci. But the AV node acts as a filter and sends out only a few of those signals. Therefore, it kind of controls the ventricular rate. But even in here, the ventricular rate is irregular, but it's definitely not as chaotic as the atria, right? Because the AV node has a filtering capability. The AV node filters impulses and the ventricular rate stays limited. But say, you have this thing accessory pathway කියලා හිතන්න. එහෙම මනුස්සයෙක්ට AV atrial fibrillation එකක් ආවොත් what's going to happen is that this fellow, this accessory pathway, the bundle of Kent, doesn't have a filtering function like the AV node. Therefore, when this also starts getting bombarded with these impulses, it starts to conduct all of them to the ventricles. So then what happens is that the accessory pathway, which lacks the rate limiting function, and the atrial impulses go to the ventricles and bombard the ventricles at around 200 to 300 beats per minute. That leads to extremely rapid ventricular response, and that can also degenerate into a ventricular fibrillation as well, if that is allowed to continue. Basically, if the heart rate goes up, if the heart rate goes very high, like at around 200 to 300 again, you have electrolyte abnormalities like calcium cycling starts to get disrupted. You have like the walls start to get stretched. So, and then you have like the development of heterogeneous regions across the ventricular myocardium as well. Once that happens, once ventricular different heterogeneous areas start to develop, what happens? All of these impulses coming from here, they encounter these heterogeneous regions. They encounter these heterogeneous regions, and the heterogeneous regions, they start developing their own re-entrant circuits. They start developing their own re-entrant circuits, and the ventricle starts going into ventricular fibrillation. We'll talk about that later. That can degenerate into ventricular fibrillation, basically, and you can have some cardiac death. That is why agents which block which block the AV node are very dangerous in Wolff-Parkinson-White with atrial fibrillation. You should never give agents AV nodal blockers such as adenosine, verapamil, diltiazem, beta blockers, and digoxin. Because if you block the AV node, you force even more of these impulses which are generated in atrial fibrillation along the accessory pathway or the bundle of Kent. And therefore, you have even higher chances of the ventricle going into ventricular fibrillation and therefore sudden cardiac death. So that is an important phenomenon that you need to remember. Another thing, what is the definitive cure for Wolff-Parkinson-White is catheter ablation of the accessory pathway. AV nodal re-entrant tachycardia with a bundle of Kent, you can easily ablate through a catheter sent through the IVC. That is the definitive treatment for Wolff-Parkinson's-White. Okay. So now we have done AV nodal, AV nodal, AV nodal, these things, arrhythmias we have done. Important thing, now say we get these ECG what are we going to do? Sorry, this one. එතකොට ඔන්න ඔය වගේ එකක් આવොත් what have we මෙන්න මේ වගේ ECG එකක් say මේ හිතන්න දැන් මේ වගේ දැන් junction එකක් ගමු දැන් මේ වගේ rhythm එකක් આવොත් how are we going to put this into our algorithm? Now first thing, is electrical activity present? Yes, there are spikes. What is the beats per minute? And when you count this one, roughly around 2 squares again, so that is 150 beats per minute. So therefore, this is definitely a tachycardia. These are what you call, now is this narrow complex or broad complex? So now these seem to be narrow complex tachycardias. These seem to be narrow complex tachycardia. Then you go and look at whether the RR interval is regular or irregular. So here seems to be regular. Now a regular pathway and therefore it can be something like this. So junctional node tachycardia. Now same sort of rhythm you are going to get in AV nodal re-entrant tachycardia. Same sort of rhythm you are going to get. Electrical activity is present. It's a tachycardia. It's a narrow complex tachycardia. It's usually a narrow complex one. AV nodal re-entrant tachycardia, it's always a narrow complex. Again, RR interval is very regular because AV nodal re-entrant a very fixed sort of re-entry circuit. So it's definitely regular. So it can be an AV NRT as well. It can also be an orthodromic AVRT as well, because orthodromic AVRT is well. When QRS complex is narrow, because the QRS complex is narrow, this can also be something like that. It can be an orthodromic AVRT. Now you see, we will start encountering a problem here. If it's an antidromic AVRT, we'll have to go along this path because that will be broad complex. Antidromic AVRT somewhat similar to delta wave morphology. Broad it will anyways definitely be this thing. Broad complex එකක්. So එතකොට antidromic AVRT එකක් මෙන්න මේ පැත්තට තමයි යන්නේ. Broad complex කියන එකට යන්නේ. So another thing to remember here is that even though this is a supraventricular tachycardia, even though AV antidromic AVRT is a supraventricular tachycardia, it is broad complex. That's an exemption to the rule. Usually ventricular arrhythmias are the ones which are broad complex. But this is an exception. Antidromic AVRT can be broad complex as well. Okay. I thought the problem I was talking about in here, now you see then everything in here, they generally kind of tend to have the same ECG pattern. Sinus, but the only differentiating factor basically is that it will have something like this thing. P-wave abnormalities, that is the only thing that differs it from a sinus tachycardia. Sinus tachycardia, you can clearly rule out if there is P-waves before the QRS complex with a normal PR interval. You can rule out a sinus tachycardia. But everything else will look pretty much similar, because now you see AV NRT එකක් කියලා කිව්වම orthodromic and AV NRT එකක් will look something like this. Orthodromic, sorry, AV NRT, just normal AV NRT එකක් will look something like this. But the thing is, P wave usually QRS එකත් merge වෙලා or immediately after QRS වගේ තමයි තියෙන්නේ. එතකොට දැන් orthodromic AVRT එකක් තිබ්බොත් again මොකද්ද මෙතන වෙන්නේ? Kind of P wave එකක් immediately after the QRS complex or merged with the QRS වගේ තමයි තියෙන්නේ ඇත්තට. Atrial tachycardia එකක්, focal atrial tachycardia. Remember we talked about that during atrial මේක කතා කරද්දී. එතකොට එතනදී QRS complexes will be narrow. P-wave morphology will be a little bit different because that's coming from ectopic atrial foci. Multifocal atrial tachycardia, again, there will be P-wave will be abnormal, and it will be abnormal in every single beat as well, because there's like there will be at least 3 different P-wave morphologies. Then focal atrial tachycardia, yes, the P-wave is abnormal, but within the ECG, every P-wave is same. All of them are abnormal, but all of them look the same to each other. Methanadi, all of them are abnormal and they look different from each other as well in multifocal atrial tachycardia. In a junctional tachycardia, again, the QRS complex, the P wave will be absent or maybe inverted, or inverted and prior to the QRS complex, or inverted and after the QRS complex. Now you see then methanadi, now the only thing that can differentiate these things, the only thing that can differentiate these things, මෙතෙන්ට atrial flutter එකක් තියෙනවා. Regular atrial flutter එකක් න. දැන් මෙතනදී atrial flutter with a fixed rate එකක් තියෙනවා. 3 to 1 වගේ හරි. කියන්නේ නැත්නම් 2 to 1 වගේ block එකක් තියෙනවා. It can have a regular pattern as well, but then again, a P wave will be very abnormal. Sorry, this is atrial fibrillation. Atrial flutter, it will be something like, you can flutter waves, you can differentiate as well. Again, P wave difference. So all of these things are actually diagnosed based on slight differences in P wave morphology. But the thing is, at our level, at suppose undergraduate level, we are not expected to differentiate between these things. I mean, obvious things like atrial fibrillation, atrial flutter, again, you can easily differentiate. But other ones, differentiating an AV NRT from an orthodromic AVRT, or from a junctional tachycardia, those things like very similar. Even a focal and multifocal atrial tachycardia, you can kind of differentiate because the P-wave morphology is abnormal. Nothing else is abnormal. You can differentiate. But these 3 things, AV NRT, orthodromic AVRT, and junctional tachycardia, all of them pretty much look the same. There is not really a differentiating factor between these things. And again, very little difference. We are not supposed to differentiate between them, at least at our level. So if you just say for all of them, if you just say it's a supraventricular tachycardia, that is enough. Yeah, so that is basically what it says in here as well. If you're having difficulty in identifying the specific arrhythmia, identifying it is whether it's a narrow complex, identifying that it's a narrow complex regular tachycardia. If you limit it to these ones, that is enough, because usually the treatment will be most of the time same for all. At least the medical treatment, not the surgical one, but the medical treatment at least will be the same for all of them. Therefore, if you just can differentiate that it's a narrow complex regular tachycardia, that will be more than enough. And usually those are, since they are narrow complex, they are supraventricular tachycardias. If you say that will be more than enough. Okay. Alright, so we finished those ones. ඊට පස්සේ we can now start moving into the ventricular arrhythmias finally. Okay, ventricular arrhythmias. We'll take a short break. Let's start at 9:50 again. 3-minute break.